Now, the World Health Organization has released its first ever global guideline on the management of sickle cell disease during pregnancy. In a statement issued on Thursday to commemorate the 2025 World Sickle Cell Day, the organization says that the guideline would address critical and growing health challenges that could threaten both women and babies. The theme of this year's World Sickle Cell Day, annually celebrated around the world on June the 19th, is Global Action, Local Impact, Empowering Communities for Effective Self-Advocacy. Sickle cell disease is a group of inherited blood disorders characterized by abnormally shaped red blood cells that resemble crescents or sickles. Let's bring in quickly Dr. Jonathan. He's an assistant professor of public health, Babcock University. He joins me from Ogun State, southwest Nigeria. Thank you so much for joining us. Sickle cell anemia is it a public health emergency? Nigeria bears the highest burden. About 2 to 3% of the population has the disease, with about 150,000 newborns affected every year. And hear this, 50 million people carrying the sickle cell trait. Is it a public health emergency?
Thank you very much for your question. Is it a public health emergency? I think the figures for themselves speak loud of it being a public health emergency. For you to have the number of individuals, over 100,000, dying as a result of preventable ailment, I think that is very clear. An indication that we are heading towards a slope where if measures are not taken, then a lot of the population will be plunged into this reality. So to give an answer directly to your question, it is indeed a public health emergency as we are seeing the figures keep soaring on an annual basis.
Here's more figures that are quite disturbing. Nearly half of the affected children die before their 5th birthday. Those who survive face a life expectancy that hovers around 21 years, much lower than the life expectancy of people with the disease in high-income nations, which is 54 years. I mean, take a look at that, 21 to 54. What are low-income countries doing wrong?
It is not a factor of location, but in my opinion, there are confounding factors. And in fact, I will put it this way, to say that the cause is multifaceted. So you have the problem of advocacy, you have the problem of information, that is knowledge, how is the population knowledgeable about this situation? And then of course you have the problem also of the health care of itself. So you will see that the status, you will see also that the figures in developed countries is somewhat a little less than what you have here because they have an improved healthcare system, of which the reason why we have these cases in the developing country, among many other factors, is also the problem of the fact that our healthcare system actually needs more attention than it actually does deserve or as it is receiving right now. So you actually have a population that is, in my opinion, ill-informed of what are the consequences of certain action that we take. So if we will improve on that, then you will see the figures will begin to adjust, as the time rolls by. So it is not that developing countries have done something wrong, or it is not that developing countries are because they are developing, so they have to keep developing with problems. No. It is a multifaceted narrative, as I have mentioned earlier, knowledge, advocacy, awareness, and then, of course, rejigging the health system on its own in order to be able to address, some of these issues that are confronting the population.
How do you think this year's theme, Global Action, Local Impact, actually addressed some of the underlying factors driving the disease in Nigeria?
The theme is spot on. and it will make and resonate and make more sense better when we contextualize that theme. And in simple terms is to say, listen, we need to look more inward as to how do we tackle this reality. So globally, it is a problem that confronts, and it has no, it doesn't care about your economic status. No. However, we can be able to have local solutions. And one of the cheapest, the easiest is information. And once information is out, people can be able to make informed decisions as to how some of these issues can be, can be mitigated within the population.
Speaking of context, one of the things that we heard repeatedly when I was much younger, I'm still very young, but much younger, is they advise us to get your genotype when you're dating someone. You know, if you're AS, your parents will go strongly against you dating someone who is AS before you eventually fall in love. In fact, these days when you go on dates, you're asking what's your genotype because you don't want to waste time. How does sickle cell disease impact daily life, relationships, and long-term goals? And what are the most significant challenges for those, you know, as a preventive measure for those who are, you know, planning to get married?
I'm glad that your conclusion question, it's almost like an answer to the, it's like you gave an answer before the question. Indeed, indeed it is quite, it is informative for any individual who will be having a partner, a lifetime partner, and or, you know, regardless of how you will want to put that into context. Now, having a partner, because it requires two individuals for you to be able to come forth with an offspring that will be clinically diagnosed to have sickle cell. And so, if both parents are carriers, it then tells you that the chances of the next generation of their offspring to come down with this ailment called sickle cell, the chances are higher. So the first point of call is individuals to be aware of what their genotype is. Okay? So once you know your genotype, then you are already on the path of prevention. However, listen, there are individuals who strongly believe that they have the solution, they can go ahead to do this. It's just like saying that, yes, you can go ahead, spend 1 week at home, and spend the next 6 weeks in the hospital, because it is an excruciating situation. You have your child, you know, always back and forth and traveling into the hospital just because you need to stabilize going forward. So in the context of what I am talking about, looking at it, you know, locally or contextualizing it, it is, in my opinion, the fastest, the cheapest, and the best solution is having people informed. That the choice that you make of a life partner, the key component is also to think about the offspring that you want to bring forth. Not unless you want to have a partner and not want to have children. But if children are part of the big equation, then you must bear in mind that the genotype of your partner is as important as the love that you profess for that person. And then, of course, I would have said that, you know, the hospital will be the next option. But you and I know that as a country, there is so much effort that is being put in place to optimize the health system. So our health system currently is on the brink of becoming, you know, getting into a new dawn. But until that is done, the current health system, you know, does not have the absolute length and breadth, depth to be able to cater for even the existing population of individuals who are confronted with sickle cell. How much more of adding to this population of individuals?
Apparently there's a big conversation going on in my MCR. A lot of people know people living with this disease, and part of the issues that they've raised in my ears is we know people who inject themselves, self-medicate. God knows where they get all these ideas from. They never get better, they get worse, and at the end of the day, you know, families lose them. Can you talk us through why people decide that certain kind of medications can heal them? How do you manage this disease, basically, effectively?
One of the earliest solutions that medical care has brought to bear is bone marrow transplant. However, it is still not absolute. It's not 100%. There are still individuals that as they grow, the body begins to repel, blood cells. I'm trying to bring this conversation as minimal as possible so that the viewer who is listening at this point can be able to understand without going into so much of the clinical jargons, as the case may be. Okay? So you have that to play. The second is you already have individuals who are able to afford it. Right from the onset, the fetus, the fetus in this context now is the unborn child, okay? They see what the genotype of that child is, and then, of course, they abort it out. But even at that, think about what pressure you're going to put your partner in such a situation. Now, it also brings the question of morality. It also brings the question of termination of life. Those are multiple narratives. Now, this injection of a thing, there is so much miscommunication. And it goes back to the point that I made earlier, that if we are able to educate, communicate effectively, let people be aware, let people know, then they will know what appropriate position to take. Now, all of these injections that we are making reference to is actually coming from the pit of no solution, because it is a genetic event that the genes of an individual which carries who the person is. So injection cannot change what your genes look like. There are even individuals, let me even add to the multiplicity of the problem. There are individuals who go to prayer home with the hope that, after a series of prayer, a long-term fasting, all of this can change. Of course, I believe in the miracles of God. I believe there is nothing too difficult for God to do. But again, I'm also an ardent believer that God gave us a brain. He gave us a brain. It is not for decoration. There are things that he has also made the brain to be able to come up to, for us to be able to know that these are things that cannot be able to bring a lasting solution. So the injections that you are hearing about, that people are taking other options, it amounts to no good.
All right.
There are even individuals who talk about other kinds and forms of medications that it will change your gene. It is of no good.
Wow. Jonathan, we're going to have
if there is anyone who
there. You made that point and you've driven it home. And well said. Thank you so much. Dr. Jonathan Dangana, Assistant Professor of Public Health, Babcock University. Thank you for coming tonight.